Well, one thing I'm going to mention to you, there's kind of 3 sections to this. And the total time is 59 minutes. And our usual practice is to not have the presentation go all that. Well, our usual practice is a 1-hour meeting and not have the presentation go for the whole hour. So I asked Sally, the 3 parts are, number 1, there's a cardiologist who's the president of the Society for Prevention of whatever, heart disease. And then there's the new president of Mended Hearts and his wife, and he's a patient. He talks about that, and she talks about what she does to support him. And then there's the third one is a question period. And Sally summarized the questions because I wanted to have some way I wanted to make the thing shorter than an hour so that we could have time to interact with one another or take care of any business or things like that. So that's what's going to happen when we get to the question part, is I'm just going to read off the answers that Sally compiled. So I'll go ahead and start this now.
I just want to interject that the gentleman, John DeMarquez, is actually the president of Mended Hearts, and his wife is the other person. So he's not he's a president.
Regional director.
Yeah.
Okay. He's the new president of Mended Hearts.
He's been president for the past 2 years. I think this is an older presentation.
Oh,
That could very well be.
okay.
Yeah.
Well, that's probably
Thank
true.
you.
Okay, great.
Thank you.
Well, see, now with all of this help, I don't have to worry about things because I've been worried about making this thing happen. So here I go. I can figure out where the thing is to click it to make it go.
John, you also have the volume exit out. See where 2 over.
All right, yeah, I got it. Now here I'm going to start it. All right.
Andrea Baer, and I am the Director of Patient Advocacy and Program Management for Mended Hearts. Today we are kicking off our webinar series on reducing your risk of heart disease. And our first topic is controlling cholesterol and diet modifications. Joining me today, first I will talk about the mission of Mended Hearts, and that is to inspire the hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. We have 285 chapters across the country, serving over 460 hospitals. Joining us is the American Society for Preventive Cardiology. The American Society for Preventive Cardiology's mission is to promote the prevention of cardiovascular disease, advocate for the preservation of cardiovascular health, and disseminate high-quality evidence-based information through the education of healthcare clinicians and their patients. Joining me today is Dr. Amit Kira, a professor of medicine at the University of Texas Southwestern Medical School in Dallas, Texas, and he is also the president of the American Society for Preventive Cardiology. I also have with me Ron Manriquez, who is the Western Regional Director and the President-elect of Mended Hearts, and have Angela, his wife. Angela Manriquez is the Western Assistant Regional Director of Mended Hearts. Everyone who is listening to us, I would like to let you know that you are in listen-only mode. There will be a time to ask questions at the end of the presentations. If you would like to type your question in the chat box, you can do that at any time. And at the end, I will then read the questions to the panel and they can ask them. Or if you would prefer, you can raise your hand, and at the end of the broadcast, I will unmute you so that you can ask your question personally. For now, I would like to turn the presentation over to Dr. Kira, and he will walk us through some of the steps on controlling our cholesterol and diet modifications. Dr. Kira?
Okay, well, thanks so much, Andrea. I really appreciate the opportunity to speak with you all today. I'm president of the American Society for Preventive Cardiology, and our organization certainly overlaps significantly and squarely with what your organization tries to achieve. And so we really appreciate this partnership on this series. I'll also say I had the privilege of speaking at a Mended Heart conference several years ago and found it to be a really valuable experience. So I appreciate the opportunity to speak with you all again today. Well, I'm going to talk to you a little bit about cholesterol control and dietary modification. And I'm going to thank Andrea in advance because she's going to help against the slides. So we'll take the next slide, please. Okay. So, first is just setting the stage to remind us of how central cholesterol is in the role for atherosclerosis. So today, most of my comments are going to be focused on what I call secondary prevention, because I know your organization mainly focuses on people living with heart disease. So when we think about atherosclerosis, the buildup in our arteries, which is the precursor to heart attacks and strokes and issues like that, we've known now since the 1800s that cholesterol is at the scene of the crime. And here is a picture. On the left, it says lumen. That's a drawn picture. On the right is actually a histologic specimen, meaning sort of from an autopsy, where you can see where cholesterol lives. So the lumen is where the blood flows, and then that yellow crescent looks like the moon is essentially what we call the lipid core, and that is full of cholesterol crystals and also has some inflammatory cells. But cholesterol is central in atherosclerosis, the buildup in our arteries. We've known that for a couple hundred years now, and I think what we've learned more recently is about treating cholesterol to lower heart disease and how central a role it has. Next slide, please. So just to remind us, so we're all in the same vocabulary a little bit, because we're going to be talking about cholesterol levels, and I'll talk about what levels I'm referring to. And I should also say, at the end, I really hope there's lots of questions. That's the best part of these sessions, so please do type in your questions and be ready for them. But we really focus on our LDL cholesterol. That's our bad cholesterol. And this slide was actually from 2001, and at that time we used to say under 100 was optimal. But we're learning that actually, and I'll show you this at my last slide actually, that really under 70 or maybe even lower is now what we're considering optimal for the LDL or the bad cholesterol. Above, certainly for someone with heart attacks or strokes, that's where we want it to be. Total cholesterol, we focus on a little bit, but not as much anymore, and I'll tell you why in a second. But the good cholesterol is the HDL cholesterol. Less than 40 is considered low, and a woman less than 50 is actually a little low, and above 60 is very good and high. The reason we don't focus on total as much as total is actually the LDL, the bad, plus the HDL good. So I've had referrals of patients with very high good cholesterol that get referred for high total cholesterol, but they actually don't have a problem in one way as we think about the bad cholesterol, the LDL. Next slide. So this is a tricky question. What is a healthy diet? And I spend a lot of my time in my clinic talking to patients about this. Every one of our new patients sees our nutritionist for free because we believe so much in the importance of diet in preventive health. But to answer this question, I'm going to go to the next slide, please. When I meet with a patient, the first thing I say is, before we talk about diet, tell me what is your goal? Because when you read on the internet, there's so much information and it's overwhelming and confusing. And I certainly understand that and hope to clarify a little bit of that. But as a heart doctor, when people are meeting me, when we're talking about diet for heart disease prevention. If your goal is bone health or weight loss or joint health, that might be a different diet. And by the way, those aren't the same thing. We'll talk about this in a little bit, but you can lose a lot of weight and still worsen your heart disease risks at the same time. Certain flavors of the keto diet can do that, not all. So those aren't the same thing. Everything on the slide is not the same. A heart disease prevention diet is what I'll focus on. Next slide. So when we look at your cholesterol panels, we all get a cholesterol panel from our doctors as a total cholesterol. We talked about LDL, HDL, the good cholesterol. There's also triglycerides, the TG here, which is the fats in your blood. And if you're trying to manipulate those with your diet, there's different things you're going to focus on. And if your focus is to lower your LDL, the bad cholesterol, you really need to focus on saturated fat. And I'll talk about that in just a little bit. You also want to reduce cholesterol in your diet. And by the way, there's things you can eat to help lower your cholesterol. That's soluble fiber. We always talk about eating oats and bran and things like that. And then there are certain things you can buy over the counter called plant sterols. But those dietary changes are if you're trying to lower your LDL or bad cholesterol. If you're trying to lower the triglycerides, some people have high triglycerides, particularly if they have diabetes or prediabetes. Losing weight helps a lot there. reducing simple carbohydrates, and increasing exercise. You notice at the top, I didn't put exercise on the top, and a lot of people misconstrue this. Exercise helps a little bit with your LDL or bad cholesterol, but it really doesn't help that much. It's predominantly diet and genetics. Next slide. So let's talk a little bit about dietary fats and saturated fat. And again, many people are probably very familiar with this, but saturated fats are whole cheese, whole dairy, butter, animal meats, and desserts, fried food. Those are all our saturated fat, and that will certainly raise your cholesterol, which we'll talk about in a second. For unsaturated fat come in monounsaturated, polyunsaturated. Monounsaturated is your avocados, your olive oil, your walnuts, and then omega-3, which is your fish or flaxseed, and then omega-6, which is a lot of your plant-based fats. So those the ones on the right do not raise your bad cholesterol. So those are okay in terms of your cholesterol. The ones on the left certainly will, and I'll show you that in the next slide, please. So here's a study just to show you, I guess those dots got blown up a little bit, but this is a study just to show you, a lot of people, ask this, does saturated fat really affect your cholesterol? It definitely does. Here's an example of that. This was a study done at my institution by one of my colleagues, Dr. Grundy, who's the chair of the new cholesterol guidelines. And ironically, this is about 30 years ago before his most recent guidelines. But here they took 22 patients, and on let's focus on the right where it says LDL cholesterol. At the bottom it says high poly. So first they put them on high polyunsaturated fat, safflower oil, and saw what their LDL cholesterol was. And on average it was about 140, still a little high, but that's what it was. Then they took the same people and they switched them over to saturated fat, palm oil or lard, and their cholesterol went up the bad cholesterol went up by 42 milligrams per deciliter, 42 points, so now is averaging above 180. So, and if you look, almost every one of those arrows was upwards, or trends was upwards. So there's no question that saturated fat will increase your cholesterol. So if you're trying to lower your cholesterol, you have to reduce saturated fat in your diet. Next slide. Now, saturated fat, the problem is you might, and you all, I know your group is very astute and follows the literature and all the things out there. And the problem has been dietary whack-a-mole, and that's what I call it. Because what we did historically from the 70s through the 2000s, we said, don't eat a lot of saturated fat, and everybody stopped eating a lot of fats. But what did they do? We ate a lot more simple carbs. So we ate whole fruit, these sugar-free sweetened beverages, fructose corn syrup, all the things, white rice, white bread, all the things that we do. And that's not necessarily good either. And let me show you what we're learning, which is about, it's not just avoiding saturated fat, but what you replace it with. Next slide. So this is a study, a little bit busy, but I'll walk you through it. This is from the Nurses and Health Professionals study that took 84,000 people. And they said what it is that, if all these people, when they reduce their saturated fat, they ask what did they replace it with? Let's walk it through. Anything on the left of the line, so the green, the yellow, the blue, that means benefit. Anything on the right, the red is bad. So if you cut out your saturated fat and instead consumed trans fat, that was bad. If you go down the fourth one, the other red, and I'm sorry that it didn't transfer right when I sent the slides in, but it says refined sugars, starches. So if you stopped eating saturated fat but started eating white bread, white rice, you were no better off. It did not help you. So this is some of that literature where reducing saturated fat didn't help. But look at the other ones. If you stopped eating saturated fat but instead ate monounsaturated fats like olive oil or polyunsaturated fats, or used whole grains, you actually did see a reduction in heart attacks and heart attack risk. So it's not cutting out saturated fat, it's also what you replace it with. Next slide. So the world has evolved. Rather than spotlighting one macronutrient, just being saturated fat's the only bad guy, but thinking about what patterns of food we're eating. And that one on the right certainly looks like what we're about to talk about, a Mediterranean pattern, really focusing on these patterns. Next slide. So to remind us a little bit about what a Mediterranean pattern looks like on the right, that's a lot more whole grains, different types of grains that people are eating, a lot more fruits and vegetables, a lot more legumes, olive oil, a lot less red meat, a lot less dairy, frankly, in terms of Mediterranean diet, fewer sweets and eggs, but a lot more fish and good oils. We see olive oil there. Now, we've known that for a while, that the Mediterranean diet looks to be heart healthy, but a few years ago, we kind of got the definitive evidence. Next slide. So this is the Preventive study. If you look at all the diet studies, one of the problems in the diet world is everything's what we call an observational study. You ask people what they eat and find out what happened to them, and then say that's a good or bad diet for a pattern. And the problem there is what people choose to eat keeps a lot of company. So they may choose a certain diet, but they may have different sleep patterns or exercise patterns or weight. So that keeps a lot of company. The best study is what's called a randomized trial, where you flip a coin and half the group does one thing and half the group does another. And that's what they did here in the Preventive study, that the best evidence we have for reducing heart disease in a nutrition study. So here what they did is they took 7,000 people, and half of them had their usual diet, controlled diet, and the other half, they put them on a Mediterranean style diet. And what you see over time, those curves start to separate. By the way, the Mediterranean had two arms in it. One was a Mediterranean diet where they had more nuts, which was 30 grams a week of walnuts, hazelnuts, and almonds. And the other Mediterranean diet was one where they did extra virgin olive oil. They gave them 1 liter a week to use liberally. Doesn't mean they drank a liter of olive oil a week, but they told them to use it liberally. The bottom line is there was a 30% reduction in cardiovascular disease events. The only dietary randomized trial we have showing a reduction in cardiovascular disease events is Mediterranean diet. So that's the pattern that we generally advocate for in our patients. And concomitant with that is making sure we're lowering saturated fat if we're trying to lower cholesterol. Next slide. So that's the dietary part of it. And I want to pivot a little bit and talk about the new cholesterol guidelines that just came out in November. So it's very timely. And the chair is Scott Grundy, who's here, my colleague here at UT Southwestern. Next slide. Now, we're going to talk about medicines a lot, but I want to remind you the number one, they had top 10 take-home of these guidelines. The number one take-home was in all individuals emphasize a heart-healthy lifestyle across the life course. So it's never, I always tell my patients, it's not medicines or diet, it's both. And for some people, it's just diet. If you've had heart disease or heart attacks, it ends up being both. But healthy lifestyle is critical. So even though I talk about medicines, I don't want to forget that. Next slide. The number two thing, which is what we'll talk about, and I'm focused on patients who, or people on this call who have already had ASCVD, atherosclerotic cardiovascular disease, a heart attack or a stroke. And in those patients, the guidelines say, as well as in 2013, the guidelines said the same thing, that if you've had a heart attack or stroke, you should be on a high-intensity statin. And let's talk for a second what a high-intensity statin means, or why are we focused on statins? Next slide. So I bet you in the question and answer, we're going to hear a lot about statins. I usually do get a lot of questions because there's certainly a lot of side effects, and it's worth talking about those. But for this, I want to tell you why is it that statins are a first-line drug. And the answer is they've been studied more than almost any drug in cardiovascular medicine that we know of. So this is what we call a meta-analysis, pulling together data. And here, 170,000 people have been studied, more than almost any drug that anybody takes. So at least we know consistently. In the orange there, anything on the left of that white line down the middle says benefit. Statins we know compared to placebo lowers non-fatal heart attacks, coronary death, stroke, major vascular events. So pretty consistently they work and they lower events. Next slide. So what's a high intensity statin? Sorry, these boxes didn't transfer in the slide set. But on the left, if you have had a heart attack or stroke, in general, that's the medicine and doses you should be on based on trials, and I'll give you one in just a second. So that's atorvastatin or Lipitor, 40 milligrams or 80 milligrams, or rosuvastatin, which is Crestor, 20 or 40 milligrams. That's what the guidelines say. If you've had a heart attack or stroke, you should be on the highest dose of these drugs. Now, of course, if you have side effects or issues, sometimes you're on lower doses, so that's okay if there's some problems. But generally speaking, most should be on those drugs and those doses. Next slide. And the reason that we say that is because of studies like this. Here's one example, but there's 5 studies like this, and they all show the same thing. Here they took 10,000 patients that had stable coronary disease. They'd had a heart attack or a stent in the past, and half of them in yellow got 10 milligrams of atorvastatin or Lipitor, a very common dose that people use. And they said, well, 10 milligrams is pretty good, but what if we give the other half a high dose, high intensity statin, 80 milligrams of atorvastatin? They saw they got a further 22% reduction in events. And the LDL, the bad cholesterol, came down from 100 to about 77 or so. So on top of being on a statin, being on the higher dose in these higher risk patients further reduce risk. And that's why it's recommended, not just from this trial, but about 4 others. Next slide. So what about, so what happened is in the past, we used to say, well, if you've had a heart attack or stroke, get on a statin, and that's great. And most people are on statins, hopefully high intensity statins. But what's happened since the prior guidelines in 2013, we've had some new drugs come out and new evidence regarding these drugs. And I'll talk about two and tell you what the guidelines say about them. So the first is a drug that some people may be on called ezetimibe. What ezetimibe does, and here this is a drawing, it's a pill, by the way, it's once a day, where that's a drawing of the intestine. So when you swallow your food and it goes down in your intestine, the yellow is dietary cholesterol. There's cholesterol in our diet that we're eating, and our intestines absorb that cholesterol that goes back to the liver, and that's how you increase your cholesterol in your blood. Well, ezetimibe, essentially what it does, it blocks it's a cholesterol absorption inhibitor. It blocks your body from absorbing cholesterol, and it lowers your cholesterol. So that's the good news, and it's easy to take. It's once a day. The downside, I guess, it's not very strong. It lowers your LDL by about 15 to 20%. Not bad, but not nearly as strong as statins or another drug we'll talk about in a minute. So definitely an option that people can take if their cholesterol is still high after being on a statin. Next slide. So the newer drugs available now are called PCSK9 inhibitors. And this slide's a little confusing, but I'm going to walk you through it just so you understand how they work. So on the left is what our bodies are doing all the time. The purple things there are called LDL receptors. So essentially those bind the LDL, those green with the dots. They bind the LDL in our blood and pull that into our liver, and that thereby lowering the LDL in our blood. So essentially your liver is pulling the cholesterol, the LDL cholesterol out of your blood and bringing it into the liver, so lowering the LDL in your blood. So those receptors are really critical there in terms of pulling it into the liver. So on the right, we have this enzyme called PCSK9. We all have it. And this PCSK9, it binds to those receptors, those purple receptors, and it causes those receptors to break down. The liver takes in those receptors and breaks them down. So then you have fewer receptors. So the more PCSK9 you have, the fewer of those receptors you have, and the less LDL you're pulling in your liver. Said another way, the more PCSK9 you have, the higher the LDL in your blood. Well, based on a lot of genetic models, which show that this is possibly something to target, they developed these PCSK9 inhibitors. These are injections, they're antibodies, and they essentially bind to that PCSK9 so that those PCSK9 leaves those receptors alone so they can continue to pull the cholesterol into your liver. Next slide. So now there's two PCSK9 inhibitors available, FDA approved. One's called evolocumab on the left, one's called alirocumab on the right. They're both pretty effective. And when I say effective, they lower your LDL by 50 to 60%. That's on top of a statin. So very potent and can be a good choice for some patients. You see those pens are essentially injector pens, pretty easy to use. And you give yourself a shot every 2 weeks, can be given even once a month. Next slide. Here's one recent trial called Fourier, where they took about 26,000 patients who had heart disease, and they randomized them to continue on their statin alone or statin plus this PCSK9 evolocumab. What I wanted to show you here is what happens to people's LDL, the bad cholesterol. So in the statin alone group, the LDL was at 92, which is not bad, but not perfect. But when they added the PCSK9, it went down to 30, which is way lower than most of us are used to seeing, although we're seeing a lot more patients with those low levels now, and they were 30 for about 2 years. This is my last slide. Next slide, please. So putting it all together, and I'm sorry again that this box got messed up, but essentially this is what the guidelines say. If you've had clinical atherosclerotic cardiovascular disease, if you look to the right, if you're very high risk, meaning if you've had a recent heart attack or multiple recurrent heart attacks or strokes, you've had one, but also you're older and have diabetes or currently smoking. So if you're higher risk, everyone should be on high intensity statin. And then if your LDL is still above 70, and that's being blocked by that box there, and I apologize, but it says if your LDL is still above 70 on a statin, you can consider adding ezetimibe next. It's a very reasonable thing to do. And if your LDL is still above 70, even though you're on the statin and ezetimibe, you may consider that PCSK9 inhibitor, the last slide that I showed you. So the bottom line is most patients, we talked about diet, incredibly important. We talked about lowering saturated fat, what is considered a heart-healthy diet, and looking at the pattern like the Mediterranean and not playing whack-a-mole with one nutrient or the other. And then we talked about drugs that everyone with atherosclerotic cardiovascular should be on a high-intensity statin. And now the guidelines say beyond that, two other things that can be considered are ezetimibe and PCSK9 if your cholesterol is still high. Okay, I think that's my part, and I'll pause and let our other speakers take over.
Thank you very much. I appreciate that. Lots of great information. We will now hear from some patient, a patient and a caregiver on some practical tips from the patient and caregiver perspective on controlling your cholesterol through diet. And I will turn over the microphone to Ron or Angela. I'm not sure which one of you would like to do these slides.
Thank you, Andrea. Being a heart attack patient, I have always had a family history of heart disease. My father died of a stroke, and my mother died of a heart attack. So I've always had that in my history, although I always thought that it wouldn't happen to me. So in 2004, I had a major heart attack. It was quite a shocking situation. The other piece I'd like to add into there is you fall into a depression, which sometimes comes with a major heart attack, and sometimes you have to work your way out of that. But having a heart attack, you kind of feel that, where do I go next? You feel terrible. You're trying to move ahead. You're trying to move ahead to a healthy lifestyle, and feeling terrible is the main thing. And the other thing is, if you want to not have a second heart attack, that always is the danger of happening after having the first heart attack. So I had to manage my high cholesterol and, of course, high blood pressure, and I started taking a series of meds, which I've been taking for all this period of time. I went back and looked at my history, and I had to write down some of the things. But basically, during my working career, I ate often at fast foods with high saturated fat, and most of the foods, they put lard in the foods to make it taste better. And also, my afternoon snack was always from the vending machines and high soda intake to give me that afternoon boost after lunch, which I knew wasn't doing good to my health, but you know, I didn't have a heart attack, so I just kept on going. And of course, try to manage my stress, which is almost impossible in a working environment. So I had to reduce my saturated fats and calorie intakes. I started reading more and more of what I needed to do. So I switched over to a vegetarian diet, and which adds more fruits and vegetables, and virtually eliminated red meat from my diet. And the only thing I have now is fish, which the new thing is to have omega-3s in your diet. So I added more fish at least once or twice a week now, and more fruits and vegetables. I do like legumes. I eat a lot of beans, and that's usually in my diet about 3 times a week, which I think is important when I'm reading and following. In addition to the statins, I just was prescribed a new drug by my doctor called Vasepa, which my understanding is a fish oil, and it's just a new drug I've been taking. So the results, I have to find out what the results of that would be as the time goes on. I'm exercising daily now. I go to the gym daily, and I do cardio and light weights. I still have a good golf game, so I want to keep my muscle together and for the swing that I use. And of course, cardio, I use the treadmill and go on that frequently. And I feel that at the end of that, I feel better. I know that saturated fat is not good. I recently had a trip to New Orleans where I ate a lot of saturated fat, and I could tell right away that I was beginning to slow down. And I was quite concerned about that, but I don't eat that kind of diet normally. So I'm going to move on from that. And also, one thing in talking to folks is that they don't check their blood pressure and cholesterol levels. Is they think they're immune since they're not sick. But you know, it's almost like an accident waiting to happen. As I talk to folks in my age group, that you need to check those levels often, your cholesterol levels often, because that's going to happen as the time goes on, just by a particular age. And A1C, which is a diabetic, I know it wasn't mentioned here, but now considered borderline diabetes, and I need to watch that as that is a new thing that's cropping up in my blood pressure and my cholesterol situation, and the blood test for A1C. That's important. And I also would have to say is that don't avoid your primary care physician or your cardiologist. It's something you need to meet with them regularly, stay on the schedule, and always take your medication. Sometimes when you feel better, you feel okay. I'm talking to a lot of folks and patients that they skip their medications and don't take them. So the combo, which is good diet, medication, and exercise is the 3 I'd have to say. And continue with a low fat. We've switched over using, Angela will talk about that in a minute, how she prepares those foods. And that's it for me.
Thank you, Ron. Angela, we'd love to hear from you.
All right, thank you. And if you can move that next slide for me, please. And after Ron had his major heart attack, I always say that Mended Hearts found us. And it was actually attending Mended Hearts meetings that I learned that high cholesterol was such a high risk factor for heart disease. When Ron had his angioplasty procedure that saved his life, I became his primary caregiver. So I had to learn how to cook low-fat meals, low cholesterol meals. And when Ron got better, I started to transition the responsibilities of embracing a heart-healthy lifestyle between us, because he was very appreciative of the changes I had made to help him feel better. And of course, I appreciated that he was a good patient. So we make decisions now that help Ron and me stay well and still manage our cholesterol and heart disease. If you are a caregiver for yourself, I do encourage you to seek out the closest Mended Hearts chapter for peer-to-peer support. I believe we all need caregivers, and it makes a difference because we learn, understand, and support each other, and share your best practices of managing your cholesterol with each other. Now, Ron's heart attack was a major life-changing event for us, and we attended a marriage encounter weekend. And it taught us to be open, that feelings are not right or wrong, and we learned tips on how to dialogue with each other. We still have talks on maintaining our healthy lifestyle. I learned that through dialoguing how difficult it was for Ron to embrace the new diet and give it the foods he liked, but we understood they were killing him. We're always working on what is best for us, and there is a lot of give and take. Ron will always need to manage his cholesterol. Ron must take his medication, must eat healthy, and exercise. I'm not a morning person, so Ron takes the lead in the morning to make a low-fat breakfast. I take responsibility for other meals. I have made modifications in our diet to support him, such as cooking with olive oil. I use egg whites. We eat multigrain breads, Quaker oats, and we eat brown rice, along with other healthy meals. Since I take responsibility for preparing the meals, I also consider ways of cooking more healthier. And so right now I am cooking with the air fryer. And it is cooking without oil, which reduces calorie intake and fat. And it, of course, significantly helps us to manage cholesterol. I do have fruit on the kitchen counter, and we add vegetables to our meals. We are proactive when we go out to eat. We choose meals like fish. When we travel, we, for example, might buy a Subway sandwich instead of a high cholesterol fast food, because it avoids us getting overly hungry, and then we're apt to eating everything. So for me, I must be organized so we don't default to our old ways. It is planning our meals, scheduling our exercise classes, and adding medication reminders into our daily routine. I have an ongoing grocery list that I keep on my refrigerator. I periodically take pictures of it, so if I'm out and I want to stop at the grocery store, I buy only what I need, and it supports our low cholesterol, low fat diet. This helps me to avoid buying processed high sugar and high fat foods. I even add snacks to our grocery list, and almonds is one of our favorites. Yes, we sometimes skip our workouts and we eat comfort food, but we don't give up, and we hit the reset button. We remain focused and organized because we want to feel good and be healthy. My suggestion is make a plan that works for you. It will help minimize your stress and frustration. And there is a song I like, Don't Worry, Be Happy. Worrying causes stress, and it may even raise your cholesterol. It has a negative effect on our bodies. I start my day by being grateful for all that is good in my life, and when I am happy and I am positive, happiness is contagious and it is good for our health. And whenever you can, relax and laugh and make things fun. Good fun is another way of healing for both the patient and caregiver. And those are Angela's caregiving tips for today. Thank you.
Thank you so very much. We will now take some questions, but beforehand, I would like to take a moment and thank the American Society of Preventive Cardiology for their partnership on this educational webinar series. And I would also like to thank Amgen for their educational grant that they were able to provide us so that we can bring these wonderful webinars to everybody. I will now take some questions.
Okay. I think you all can hear me now, correct? All right. But interestingly, I'm not hearing you.
Yeah, I'm sorry, we can, John. I had muted everybody just to reduce the background noise. But yes,
Okay.
you're loud
All
and
right.
clear.
Okay, thank you. So what I did was, or actually I asked Sally Duell, who's on the program committee, to try and shorten this thing down. So we've gone about close to 40 minutes now. And I thought I would, Sally graciously agreed to summarize the questions. And I can read through them and that'll shorten the time down. And then we can have time for ourselves.
Mention one thing, or am I muted? No. I just wanted to mention the questions section in the program takes about 25 minutes, if that makes a difference, if we want to, if it's worth trying to shorten this by just reading my summary. I think I tried to capture the main points of the questions, but it would be 25.
I think your summary is better than going through the full 25 minutes. To be
Okay.
honest with you. Just not that my vote carries the day, but John and I talked about this, so I think why don't you do your summary?
Okay, so Angela, the wife, question one is, what does she like about the air fryer? And Angela's answer is she thinks it makes the food taste better, so she likes it. Second question is, how did Ron make the radical change from traditional diet to vegetarianism? And he said he went cold turkey. From the first day in the hospital, he asked for a vegetarian diet, and he's been able to have that since. Question for Dr. Kira: what kind of milk is the healthiest? And he said that skim milk is the one that should be fine for everyone. Children should have whole milk until age 2. So that's his answer. Another one for Kira was, Dr. Kira, any vegetables bad for you, such as sweet potatoes? And his answer is basically things like regular potatoes. Anything that's white is going to be bad for you, probably. Well, not white beans, but potatoes and white bread and so on. He likes the leafy greens, but not too much of them if you're on blood thinners. This was a question for Angela. I don't know if this applies to any of us because I'm not sure any of us have young children, but what do you do if a kid doesn't like the Mediterranean diet that you're preparing and presenting? And her answer was, well, if I make mac and cheese, then I chop up some vegetables and put it in there as well. And if they want a hamburger, then I serve some fruit along with it. So she just tries a kind of a gradual approach. Dr. Kira was asked about recommended weight. And I think the key part of that answer is that your cholesterol is more important than your weight. If you have a choice between carrying a little extra weight and having a high LDL, you want to go for the lower LDL. So two of the questions have to do with the statin side effects, and that primary one seems to be that people have leg cramps at night. And somebody want to make a comment? Okay, because we can talk to each other here. I'm not wanting to be the only voice around. So he said, well, Ron's answer was, look, I do get leg cramps, but the medication really works and really does what it's supposed to do. And so I take it and I just basically tolerate the leg cramps.
Can I ask you a question? This is still going. Is there a way to?
Somebody else asked about that.
Where is that?
It's on your sound.
On my sound?
You're getting interference.
Yeah, Carter needs to, he needs to mute himself. Yeah. Carter, we had to solve while you were talking.
Okay. So the last question was, and there's some, I'm just jumping to the last question. So this woman had terrible leg cramps at night, and any ideas how to help the leg cramps? And the question was this food supplement called CoQ10.
CoQ10.
And CoQ10, okay. He didn't really say much about that. He said, I can't give individual advice to an individual person. I can only talk in general. But apparently, studies on CoQ10 have shown that it helps some people, but not others. So it's not in the guidelines, but it does help some people. The other thing I'll mention about that is, let's see. Oh, the next question was, what about BMI? And somebody knows what that acronym means. I can't remember right now.
Body mass index.
Okay, thank you, Bill. So he said he likes under 25, which is normal. If it's above 30, it's important to talk to your doctor about weight loss. But for some situations, weight loss can make a big difference, particularly in diabetes. And somebody asked about portion size, and Dr. Kira says, a plant-based diet is much lower in calories than a traditional diet. And if you don't have, next question, if you don't have buildup in your arteries, but you have a family history of high cholesterol, you need to take a statin. Dr. Kira says, if your cholesterol is high, even if you don't necessarily have atherosclerosis, but if you have high cholesterol, it's a good idea to take the statin and get that cholesterol down. Here's a good question. It's one that faces all of us when we get out of the house and we don't have control of our food. How do we deal with that? So Ron said, well, I went to New Orleans, traveled to New Orleans, and I was eating everything that they served, and I could feel that I was slowing down because the cholesterol was building up with this non-vegetarian diet. And he said, so when you do travel, what you need to do is you need to ask for the kind of food that you need. And whether that's in a restaurant or in somebody's home or whatever, you need to ask for the food that you need. And so that's the summary of the questions. And that's about the time that I wanted to do it. I wanted to give us an extra 15 minutes at the end of our time so we can finish up in an hour. So if any of you have questions or comments or things you'd like to see in future programs or anything like that, I'd love to hear about it.
Thanks, John.
So that's all we're gonna do program wise, John, just to be clear.
What's that, Carter?
I'm sorry, so that's the end of the form or organized program and
That's
the
the end of
Q&A?
the presentation. That's correct.
Okay,
So what I did was I wanted to shorten the Q&A so we'd have some time among ourselves before the hour was up.
right. I think if I've accomplished it, I've unmuted everybody. I apologize, I muted you all because background noise is really destructive, or not destructive, distracting. I'd like to make a joke that there's going to be a test on all the information that was in the video, but that's probably I'd probably fail it. You know, I don't know if one of these things has ever ended early, but you know, maybe this will be the first time.
Yeah, I make a suggestion, Carter.
Sherry, are you?
Yeah, I have something I think I should say.
Sure.
I mean, maybe you people know. Can you hear me?
Yes.
We can't see you.
Yeah, we can.
Well,
No.
just the upper part.
Well, we can see you at the top of your head.
All right.
Thank you, Sherry.
Anyway, in the Chronicle, in the obituaries, Arthur Klatsky has passed on. He was one of the founding members of our chapter, along with Eileen Lucas. I will contact Annette and ask her to send a card for our chapter. But I thought, I don't know how many people that are here remember him. He came into our group a few times. But one of the interesting things is it says, any person wishing to offer a gesture of respect can make a charitable contribution to Doctors Without Borders in his honor. Alternatively, or additionally, they may purchase a good bottle of wine and dedicate the first glass to his memory.
That's nice.
Because he always came and talked to us about wine and dark
Wine and
chocolate.
chocolate.
Right. Thanks, Sherry. That's a good idea.
I believe Arthur Platsky was literally the founder of the chapter, from my stories from people like Rosemary Carita.
I have a request. We've got 4 people who've joined us here whose names I don't recognize. Maybe others of you do, but I wonder if you all could introduce yourselves. And so one is named Natalie. Is Natalie, can you hear me, Natalie?
Yes, can you hear me?
Yes.
Yes.
Yes, I'm Natalie Dunlap, Meacham Carter's sister. And this is my first meeting to attend. And unfortunately, I missed a bunch of the first half, so I'll ask Carter how to get those slides.
Well, we welcome you and thank you for joining us. The next one who's on mute is going to have to be unmuted is Alan Kren, K-R-E-N. There. Okay. Would you like to introduce yourself?
Sure. Actually, this is the second time I've attended, but that's okay. So,
Okay.
yeah, but that's fine. Yeah, it's you know, a lot of times on Saturdays I'm out doing something that I forgot last month. It was like, why we were riding bikes.
Good for you.
All right.
Are you a
And-
member of the chapter, Alan?
I think so.
Okay, great.
I
Great.
think so.
Good.
Do I have to pay dues? I'll pay dues. I don't know.
Well, maybe you could put in the chat, Alan, your phone number and your email so we can make sure that we can contact you.
No, I've done all that. Yeah, I got the email about the date.
Yeah, I've got a
Okay.
list.
Yeah,
Okay,
you got
great.
all that? Okay.
The next one I have here that's muted is Kelly Connors. Kelly, would you like to introduce yourself?
Yes, right. I don't know how I found this group or this invitation to the webinar, but I was very interested because I have high cholesterol and I've kind of refused my doctor's suggestion that I get on a statin. And I've been trying with diet, but looking, for this information was great. I think I'm going to, follow my doctor's recommendation. And if this is a chapter that I can join, I would like it because I know that that my dad also had high cholesterol and he was a marathon runner and he could eat an onion like an apple. I didn't feel like, I know it's hereditary and not so much dietary for him. So I need a lot of support.
How did you find us, Kelly?
I'm trying to remember because this morning it was on my calendar, but I was trying to find the email that it came to. I have like 4 email addresses, including my work. And I'm just trying to figure out, how I found this, but it really did pique my curiosity. So I don't know if
Okay.
it was in Nextdoor, if it was, I'm not sure.
Well, we hope you can continue and we'd love to see you at the next meeting and have you participate. This is just a volunteer little group that we all get together and support one another.
Hey,
Thank you, Kelly.
Real
Thanks.
quick, John, this is Alan. I'm gonna jump in here. I'm gonna offer some unsolicited advice is get on the statins. Real quick, my story was my cholesterol was okay. I was super athletic, super good diet, no history of heart disease in my family. Sure enough, those are plugged up and ended up having a triple bypass. So this stuff happens and I was not on the statins. Okay. I told my doctor I'd do it with diet, and exercise. So you always end up thinking, boy, it would have been a lot easier just to take the statins and spend that week in the hospital and all that nonsense afterwards. So it's unsolicited advice, but I feel free to give it to everybody.
It's great. Thank you.
Well, it's also your experience, and so that's really
Absolutely.
important.
Yeah, it's my experience. Yeah.
The next one that I have that I don't recognize the name is Jerry Cope. Can you hear us, Jerry? And would you like to introduce yourself?
Actually, it's Natalie again, and I'm using my husband's laptop.
Ah,
Since it's Jerry, he's taking
Okay.
a nap.
all right. All right, well, that's good then. So it's by my clock, it's 10:54. Does anybody have anything else they'd like to add?
I would suggest, John, I don't remember the exact title. We always meet the first Saturday of every month for those who are somewhat new to us this time. And it's always at 10 o'clock in the morning. And the topic next for the month of June will be, I think, a follow-up on
It's Alzheimer's.
in the heart,
Part
right?
2.
Okay. Well, thank you all. This has been,
John?
Yes.
I don't want to step on your comment. I'd just like to say for the several people who are new to the group, who may not know, Bill, who's this is the Hollywood Squares, Bill, who's in row 3, and Kathleen, who are above him in row 2, have been, the sort of the engine behind this chapter for a long time. And as you may not know, they're moving locally to Arizona. We hope that they'll still stay involved virtually, but many of their roles are being reassigned, and we can't. I'm a relatively late addition to the chapter 3-4 years ago, but I can honestly say I'm not sure the chapter would have been here if it hadn't been for the two of them in the last 10 years.
Well, thank you, but that's
Thank
probably
you.
not true, because there's an awful lot of people who have contributed. And that's been one of the secrets and the strength of this chapter, is it seems to go, whether it's Arthur Klatsky or Elaine Lukes or Steve Potash or whoever, the chapter keeps going along, and it's now in, I believe it's about 30 years, 33 years, something like that.
Yeah, I should, sorry to turn this on, but this kind of came in the mail. I didn't know what to do with it, but this is from National. I don't know if it's probably too glide. It's basically acknowledging that our chapter's been 188 from February 1993 to February 2023. And it's signed by Ron Marquez, who we just saw. So I don't know where we're gonna, if we had a clubhouse, I'd hang it in the clubhouse, but we don't have one. So.
Kaiser Clubhouse.
There you go. Anyway, the other thing I'll just make as a pitch. I mean, so maybe some of you found this through, the efforts where, we have the newsletter, and I've been the last 3 months putting notices in the Piedmont Post. Kelly, your comment about next door is actually an interesting avenue that I'll advise, but it goes without saying that COVID, really created somewhat of a headwind in terms of our chapters, enrollment. Primarily the way we find new members is Bill has been a longtime visitor at the Summit Hospital. I've been one for 3 or 4 years, and that's, I won't call it a recruitment phase, but that's kind of a place where we get to talk to people one-on-one in their hospital room. But during COVID that was shut down. It's now back up and running, and we actually have 2 new visitors coming on board, it sounds like, but we definitely need outreach. The more people we get involved, the stronger the chapter becomes. So if anybody, has, the members of the chapter have heard this pitch before, but for the new people, if you have anybody who you think this would be of interest, it's basically, information, and the word fellowship may rub people the wrong way, but it's just, having other people who've been through the same situation. We are just, not to let the cat out of the bag, but it looks like we're about to, pretty soon, in a couple of months, go back to in-person meetings. But we will still broadcast them Zoom. So, we'll give people the choice of coming in and really seeing each other or staying remote. But
Yeah.
so that's all I have to say. And I thank everybody for staying on this long.
I have one thing.
Yeah.
Kelly, Connor, I think you might take a look at the meeting chat. Kelly Connors put her email address in there for you.
Oh, okay. Wonderful.
So it's kelly@hotmail.com. Easy.
Great.
Oh, it's Connors Kelly. Connors_Kelly@hotmail.com.
Great. Thank you. Thank you,
Sure.
Kathleen.
You're welcome.
All
And
right.
Carter, I'll mention that she says she found out about us in the Piedmont Post, so your article had.
Oh, good.
Excellent.
its intended
We have
effect.
one hit.
Yay. Now she gets the gold
That's
star.
more than we've ever had before, so
Yeah,
congratulations.
good. Keep them coming.
Well, come back to the pitch comment. I mean, if you have any other venues in which to publicize these things, by all means, let me know. The Piedmont Post is, a fairly small circulation. We happen to be good friends with the owner publisher, and he's happy to put those articles in. But there's obviously a lot of other places that we could publicize ourselves. So there's no NIH here. Okay, I'm going to say goodbye. In my window, it looks like the rain has stopped. So
Yep.
Maybe we all get outside and
Take a walk.
do
Yeah,
some gardening.
exercise.
Okay, I'm gonna go ahead and shut it down.
Okay.
Thank you,
for your
John.
attendance.
Thanks,
Bye.
John. You
Thank
did
you,
a great
everyone.
job.
Thank
Great
you.
job.
Yeah, good job.
See you. Bye.
Bye.
Bye.